All right, welcome to The Explainer. Today we're diving deep into a true cornerstone of antimicrobial therapy, metronidazole. We're going to break down everything from its pharmacology and clinical uses to the really nuanced details you need to know for safe and effective prescribing. Let's get into it. This quote really hits the nail on the head. It perfectly captures what metronidazole is all about. It's not a shotgun, it's a sniper rifle, a precision weapon designed to go after those unseen enemies that thrive where there's no oxygen. So, with that in mind, let's start our deep dive. So, here's our game plan. We'll start with how it works, then move into its key clinical uses, practical dosing, and of course, safety. We'll also cover its use in special populations, like during pregnancy, and wrap up with the big picture, stewardship and clinical challenges. Okay, Section 1, Mechanism and Spectrum. First things first, let's get down to the fundamentals. How does this drug actually work? So what are we looking at here? Well, at its core, metronidazole is a bactericidal antibiotic, and the key word here is narrow spectrum. It's not for everything. This thing is a specialist. It works exclusively against anaerobic microorganisms. Think things like bacteroids, Trichomoniasis, or Giardia. And how does it do it? Well, it gets taken up by these anaerobic bugs, and inside them it gets converted into a toxic form that just shreds their DNA. That leads directly to cell death. So it's not a broad-spectrum hammer. It's a finely tuned instrument, and that specificity, that's its biggest strength. So now that we know how it works, it makes perfect sense where we use it, right? Its specific target profile makes it an absolutely indispensable tool for a whole range of infections. Let's look at where this precision weapon gets deployed. Okay, first up in the world of gynecology, it's a heavy hitter. It's a go-to first-line agent for two of the most common things you'll see, bacterial vaginosis and the protozoal infection Trichomoniasis. Then we shift to gastroenterology, and its role here is just as critical. It's what we use for amoebiasis, whether it's amoebic dysentery or even liver abscesses. And, of course, historically, it's been a key player in treating mild to moderate C. diff infections. And this is where its importance in polymicrobial infections really shines. Think about things like pelvic inflammatory disease. Metronidazole is a vital part of the combination therapy you need there. It's also routinely used for surgical prophylaxis, whenever you're worried about anaerobic bugs getting in, like in abdominal or GYN surgeries. All right, on to Section 3. Practical dosing. This is where the rubber meets the road. And let me tell you, dosing metronidazole is definitely not a one-size-fits-all situation. It's going to change and change a lot depending on the bug, the location, and just how sick the patient is. Just take a look at the variability here. For something like bacterial vaginosis, you're looking at 500 milligrams twice a day for 7 days. But then for trichomoniasis, boom, a single 2-gram dose and you're often done. Now contrast that with something more serious like amoebic dysentery, where you're pushing 750 milligrams 3 times a day. It really drives home the point that you have to know exactly what you're treating to get the therapy right. So let's walk through a quick case. Picture this. A patient comes in, high fever, severe abdominal pain, classic signs of severe pelvic inflammatory disease. In this scenario, metronidazole is absolutely essential. Why? Because you have to cover the anaerobic component of what is definitely a polymicrobial infection. The regimen is pretty robust. We're talking 500 milligrams, often started IV, twice a day for a full 2 weeks. And, this is key, it's always part of a combination therapy to cover all the other bugs. And that case really brings us to a crucial clinical pearl. When you're dealing with something complex like severe PID, especially if there's high fever or the patient is immunocompromised, you cannot manage this in a silo. It's just not going to work. A multidisciplinary approach, getting gynecology on board early, is absolutely paramount for a good outcome. Okay, so we've talked about what it's good for. Now let's talk about the other side of the coin. No drug is without risks, right? So understanding the interactions and side effects is fundamental to prescribing it safely. Let's start with the most famous one, the one everyone knows about, alcohol. Here's what happens. Metronidazole blocks an enzyme called aldehyde dehydrogenase. So if your patient drinks alcohol, acetaldehyde builds up in their system, and they get this nasty Disulfiram-like reaction. We're talking flushing, nausea, vomiting, it's miserable. So the advice to the patient has to be crystal clear, no wiggle room, 0 alcohol during treatment, and for at least 48 hours after that final dose.
The next big one to watch out for is with vitamin K antagonists, like warfarin. Metronidazole messes with their metabolism. As you can see here, a patient with a stable INR can suddenly have a dangerously high INR when you add metronidazole to the mix. That means their bleeding risk goes way up. The bottom line? If you have a patient on warfarin, you must monitor their INR diligently and probably get the thrombosis service involved.
All right, moving on to side effects. The one you'll hear about most often is dysgeusia, or, a weird metallic taste in the mouth. It's usually not a big deal, but it becomes a really important counseling point when you're talking to a lactating mother, because that taste can actually get into the breast milk. And that brings us perfectly to our next section, special populations. Prescribing for patients who are pregnant or breastfeeding is always a balancing act, right? You're weighing the benefit to the mother against any potential risks to the baby. This chart really spells out the guiding principle when you're treating bacterial vaginosis in pregnancy. Look at the difference. If you give oral metronidazole, the systemic absorption is pretty high. But if you use a local therapy, like a vaginal ovule or cream, the absorption is way, way lower. So to minimize any exposure to the fetus, local therapy is strongly, strongly preferred.
So let's break down the key takeaways for pregnancy. For BV, the mantra is go local. Use the ovules or cream. For trichomoniasis, yeah, you can give that single oral dose, but it's much better to wait until the second trimester if you can. And for amoebiasis, the best choice is actually paramycin, which isn't absorbed, so you can hopefully avoid metronidazole entirely.
Okay, what about lactation? Well, generally it's considered probably safe. But remember that metallic taste we talked about? To deal with that and minimize the baby's exposure, practical advice is everything. Tell the mother to take her dose right after she finishes a feeding. Now, if the baby refuses to feed because of the taste, you can advise her to interrupt feeding for about 12 hours after her dose and just pump and discard the milk during that window. And remember, vaginal clindamycin cream is always a good alternative to have in your back pocket.
All right, let's bring it all together in our final section. We need to think about all this within the bigger picture of antimicrobial stewardship and the challenges we're facing out there in the clinic every day.
So a few really important points on stewardship and warnings. First, resistance. We're starting to see more and more reports of it, especially in GRD strains. Second, C. diff. The guidelines have really shifted here. For severe C. diff, metronidazole is no longer the go-to. You should be reaching for fidexomycin or oral vancomycin if they're available. Third, partner treatment. For that patient with recurrent BV, you might need to consider treating her partner to stop that ping-pong effect of reinfection. And for trich, you need to discuss partner notification. And finally, the main contraindication is what you'd expect, a known hypersensitivity or allergy to the drug itself.
Okay, time for a quick knowledge check. Let's put this into practice. You have a patient with recurrent bacterial vaginosis, and she's already failed vaginal metronidazole. What's an appropriate oral regimen to try next? And the answer is a single high-dose oral regimen. You give 2,000 milligrams, that's 4 500-milligram tablets all at once. What's the thinking here? Well, this strategy blasts the system with a high concentration to kill off the bugs, potentially overcoming any low-level resistance or even just the adherence issues that can come with a longer multi-day course. It's a powerful tool for a very common clinical problem. And that's our deep dive on metronidazole. Thanks so much for joining this explainer.